TopMedTalk.
All right. Well, this is TopMedTalk at Anesthesiology 2018. We're here in San Francisco at the annual meeting of the American Society of Anesthesiology. We're actually here on on the Smith's Medical booth 1519 in the Connection Center. I'm Desiree Chappell, host of TopMedTalk, and I have here my co-host today, Monty Mythen, editor-in-chief of TopMedTalk. Hello, Monty.
Hi, Desiree. Good to be here.
It is good to be here. So we're as whenever you're doing these type of things at these events, running just a little bit behind, so hang with us. We have Angie Edwards we're going to be talking to here, and then Stuart Grant will be coming up momentarily, or in about 20 minutes. So make sure to hang with us. So, Angie Edwards, thank you so much for being with us today.
Thank you for having me
on TopMedTalk. And Angie is the assistant professor assistant professor of anesthesiology at Wake Forest, and she's also the president of SPACI. Angie, can you tell us a little bit about what SPACI is?
I'd be delighted to. SPACI is its acronym is the Society for Perioperative Medicine and Quality Improvement. It is a multidisciplinary international society with a focus on preoperative medical optimization. We've expanded our outreach over the years to include educational modalities for internal medicine physicians, hospitalists, anesthesiologists, and any ancillary provider who has an interest in the area. So we have incorporated, we started our initial focus on preoperative clinics, but have really expanded into more of a perioperative focus. So now looking more actively at postoperative outcomes and bringing our hospitalist group sort of in the perioperative world to sort of collaborate more on our better understanding of how to improve preoperatively what our patients are going to experience postoperatively.
That's great. What are some of the initiatives that you guys are working on right now in your organization? So the hot topics.
I'm glad you asked. Fantastic. We just came out with a set of guidelines or a consensus statement on preoperative frailty, how to implement a preoperative frailty program into your practice, and that's been published. I think that was published about 6 months ago. The next step is actually looking at smoking cessation. So we've got a group together that's looking at some guidelines and consensus statements on what to do with preoperative smoking cessation, with an idea that this is going to impact postoperative pulmonary complications. So, there's a large group of us that we seem to have established how to manage preoperative cardiovascular risk. Yeah. We've got that down. A few caveats here and there, but one of our biggest pieces that I think we're missing is how to impact our patients' postoperative pulmonary function. Mm-hmm. So how do we minimize risk in that population? How do we impact those who have COPD, occult COPD, who's unrecognized? I'm from the Southeast, and sort of where tobacco was raised and born and bred.
I'm from Kentucky,
right?
so it's the same.
So most of our population has grown up with tobacco. Some of my patients have been smoking since they were 10.
Yep.
They don't recognize their symptoms. They're asymptomatic because they don't move much, or they've always grown accustomed to being dyspneic. So their symptoms and may not necessarily quantitate their degree of occult COPD. So, what are we doing with this population? So this is where sort of our society is sort of reinvigorating our focus. Just on one of the points, but we have certainly a multifaceted approach. Everyone has unique and different interests. So our conference calls and our engagement with our members on the forum on our website is much more extensive.
So our theme for this weekend here at Anesthesiology 2018 is all around enhanced recovery. So improving outcomes. And that was kind of what I wanted to talk to you a little bit about today. And you touched on smoking cessation. Let's take that for example. Now that's a component of enhanced recovery is, talking to patients about smoking cessation. And we were talking about some of the different elements and different methods now of smoking. Things are changing a little bit in society right now. So how are you guys addressing that through your organization and what you are focusing on?
That's a big question. We have When you talk in terms of smoking cessation, I think traditionally we look at tobacco. So tobacco cessation. There are several mechanisms. I think a lot of this has to be done on the preoperative, even before the decision for surgery, because you're looking at optimizing at about a 4-week window out. So if we can get our patients to recognize the ill effects of tobacco and begin that process at a significant portion of time out, we could potentially improve their outcomes. There have been several recent publications. One is an e-learning module that was published by one of our members, looking at just educating our patients on the ill effects, and I think that's had a significant impact. In terms of the alternative modalities, I think the latest thing, and I know this is common in the United States with our younger population. I think, 10 to 15, 20 years from now, we're going to see much more of this. The alternatives, the vapes, the e-cigs, and everything else that's come up. I don't know, Monty, are you seeing much of that?
We are, but I think the decision was made by the NHS that it's okay to vape if it gets you off smoking. So I think you can actually get NHS-supported vape now.
Oh my gosh!
Because the healthcare benefit of vaping compared to smoking is so great. Now, what you don't want to do is you don't want to take vape-naive individuals and make vape the new alternative to smoking, and that's the risk in the balance.
Yeah.
Because now some of the kids might turn around and say, "Well, I'm just going to go around vaping because it makes a smoke signal. It makes me." Maybe look cool. I think it makes you look stupid, and you get what you want out of the nicotine. So I don't where that balance is here.
I don't think there is a balance.
Okay.
I have teenagers, so I'm a little bit more in tune with that world. But I don't think there is. I think I had a patient not long ago who educated me on what was in his vape, and he'd been vaping for 8 years and really did that most of the day. And I thought, with everything that's in that, how do we know what's going into their lungs? How do we know what's coming out? So I think that we have a lot of work ahead of us, looking at that and seeing what's coming. I think alternative options are probably an ideal mechanism, but I think we have to look carefully at what our patients are using.
Yeah, we had actually at EBPOM in Atlanta, we had a great session, in Chicago as well, but we had some great sessions about smoking cessation and talking about some of those things. So I would encourage you guys out there listening to look at that.
And I think that the messages we took from all of those presentations was there's a not insignificant investment required to help many people stop smoking properly, but there's a massive return on it.
Yeah.
So it's money extremely well spent, but it's rare for people to be helped just by you should give up smoking, or the poster or the T-shirt. And it needs quite a lot. For some people, it needs quite considerably large amounts of support.
And their clinics, preoperative optimization clinics, they're specifically focusing on smoking cessation,
Well, I see Sol Arrington out there. He may want to comment on the smoking cessation. He says he's too far away to hear. So we're talking about smoking cessation in this session, Sol. So if you want to make a comment about that in a second, please don't hesitate. We'll get a microphone to you in a moment. Our support team is all over this.
You bring up an important point of medications and alternatives. I think we also in the preoperative world have, in terms of enhanced recovery, need to focus also on medication management. That's one of the components of ERAS as well. And so, how do we address? We know how to address a lot of the medications, beta blockers, insulin, statin therapy. It's pretty common. Yeah. But alternatives, in terms of some of our immunomodulators with our patients, I think there's a whole host of literature that's not yet clear on what to do with some of these immunomodulators in terms of minimizing the risk of postoperative infections and with the recrudescence of disease that they're treating.
Hold on one second. We do have Saul now on the line.
Hi. Hello.
Hey, we were talking about smoking cessation, Saul, and we know that at Duke you've had some experience with your clinics.
We have, and what I've grown to appreciate in the last years is it's a complex science. Indeed, smoking is a chronic relapsing disease like so many other chronic comorbid medical diseases that we manage. And I think what we have to evolve to appreciate is simply recognizing that smoking is bad for you and quitting smoking is good for you, that recommending to our patients that they stop smoking because it's bad for you is just simply not enough. That in fact, James Davis, the internist at Duke, who I work with and runs our smoking cessation program throughout the entire Tri-County area, has really taught me that the people who already have tried to smoke because they recognize it's bad for them have. And the people who are currently smoking are people who just simply can't quit easily. And that's the population that we have to really appreciate, is the group that we see who are coming for surgery and smoke. And so it is not good enough to simply refer them to a 1-800-QUIT line or give them a patch and expect that they're going to comply, because they want to and they can't. And that there really is a need to focus on the psychosocial as well as the pharmacodynamic parameters that portend this very difficult population to learn how to quit smoking.
And is it, Sol, I get the impression from the presentations I've heard at the EBPOM meetings that you run, is that the majority of smokers over a particular age, 40, 50, whatever it is, the majority actually want to stop. It's not that the majority want to keep smoking.
That's exactly correct. And it's multifactorial, as you would presume, whether it's genetic or whether or not it's because your mother liked your sibling better or you have an oral fixation or anything in between from that truly pharmaco-induced addictive sort of personality. But these are people who need very personalized evaluation to understand the essence of their cause of smoking. But to simply presume that they haven't been taught of the adverse effects of smoking and they weren't appropriately motivated to try to quit is, I think, a very bad and dangerous assumption.
So who's paying to get them off? Is the insurer paying? Is the hospital paying?
Yeah, so smoking cessation counseling is reimbursable, and there's a whole, if you will, I'll say economic science to establishing a smoking cessation clinic where one could capture not just the E&M and other procedural related, if you will, tools and techniques that enable a successful pathway. So it's a self-sustaining program. In fact, it can be a very lucrative in the right management setting.
Angie, is that some of the things that you guys are addressing in SPACI?
Yes, actually. There's, much like Saul mentioned, one of the biggest challenges is to set up the system, to establish the patient population and refer them appropriately in the appropriate time frame. But again, you can capture E&M for this and have reimbursement for that. I think in time we may see that even the insurance companies will reimburse for smoking cessation preoperatively.
Well, and I think it's also great to bring in that multidisciplinary team, so another aspect of how to utilize this.
This is one of those instances where your pre-op clinic cannot be your one-stop shop. You've got to have many resources available to you, and especially for the patient. I think the quit lines are beneficial, online resources are helpful, but it is not just a day-to-day issue, it's an hour-by-hour issue. But again, with the focus of if we can capture the patient during that preoperative moment, that teachable moment where they're motivated to improve their physical health, to improve their outcomes, I think that's probably our best opportunity to address that. So
you started to talk about medication management and things like that as part of improving outcomes in the perioperative setting and in enhanced recovery as well. And so what are some of the areas that you've been focusing on when it comes to managing medications through the multidisciplinary team?
Well, our patients come in on a multitude of medications for whatever comorbidity they have, and so it's comorbidity based if you think about it in terms of systems. I think from a cardiovascular standpoint, we have managed heart rate modulation. Beta blocker conversation is an entirely TopMedTalk discussion in and of itself. Anticoagulants. If you move past that, and also glucose management with insulin, I think we pretty much know what to do with the insulins. You look at the immunomodulators. We have patients, are very sick patients, our rheumatoid arthritis patients, those who have inflammatory disorders. And I know that's been a big topic in terms of addressing prehabilitation, improving outcomes, is the inflammatory disorders. What are we doing with our immunomodulators? Are we appropriately addressing those? So, everyone is slightly different depending upon why the patient is taking them. It is very patient-specific, and it's case-specific as well, because some of the biggest concerns with these agents are whether or not they're going to increase your risk of infection first, and secondly, whether or not you're going to have a recrudescence of the disease you are treating, specifically our lupus patients or rheumatoid arthritis patients. And so I think we have to sort of balance the approach to cessation and timing with the surgical episode itself, and then also reinstituting those medications. So again, looking at the perioperative approach with that specific population and those specific agents.
Yeah, I'm sure there has to be a lot of coordination in that as well, trying to make that work. Well, one of the other topics that we had talked about offline that I'm very passionate about too, and here at TopMedTalk we talk a lot about, is the expectations of patients. And whenever we're focusing on patient-centric care and them engaging in their own care, to make sure that they understand what the expectations are of them and what they expect of us and how that affects kind of the outcome, the ultimate outcome of their recovery.
You bring up a great topic, and that's the conversations that we have before surgery and the conversations that we're engaging families in. So it's not just the patient. I think you have to engage families as well, because a lot of the conversations that happen after clinic, surgery clinic, primary care clinic, pre-op clinic, will then occur at the dinner table. So, what are patients' expectations going into the surgery? Most patients expect a better outcome. They're having something fixed. They want their hip fixed. They want their knee fixed. But what are the expectations in terms of return to function? So what kind of function? I don't think anyone expects to be in a rehabilitation center for a prolonged period of time or for any period of time now. So, Monty, I'm curious to hear what you all are doing, too, in terms of establishing patient expectations up front. Are you looking at quantitative measures in terms of questionnaires? There's always the World Health Organization questionnaires that can be used. Sometimes that's not always applicable to every patient. And then on the outcomes, are we looking at, quality recovery scales?
So patient-reported outcomes have been established in a relatively limited range of surgical procedures in the United Kingdom for a number of years now. And I think it's matured to a point whereby we see great value in it from the point of view of giving truly informed consent. Interestingly, it does not appear to have driven patients away from surgeries. It has allowed the government in some situations to turn around and say there are clearly a set of surgeries where there is overall, on average, no benefit. Actually, there's a little bit more harm than benefit if you look at a whole population. So if we take, I have to quote the knee replacement example. If we look at our knee replacements, 70% of the patients who have a knee replacement in the NHS fill in the questionnaire afterwards, and 19 out of 20 report that their knee is better. I'm sorry to keep quoting the same stats, but using the quality of life measures, 4 out of 10 say their life is no better, and 3 out of 10 say their life is worse. Now, we don't know if that would have happened anyway in the passage of time, because it's just the age that they have it done. But
Interesting.
That we have no one's yet settled on the perfect. There are a number of different scales recommended, quality of life scales, etc. And there has been some work done. Mike Grocott was here with the compact group to standardise the measures that might be appropriate for following, whether it's a sort of quality of recovery score or whatever it is. But I think increasingly people are focusing very, very much on did the patient a year later get out of surgery holistically what they were hoping out of it, as opposed to this bit or that bit is now fixed. I think Sol wants to come in on that. Sorry to...
Thanks, Monty. Enjoy the conversation about PRO. We're just scratching that surface now in the States, both from a what is the most appropriate tool and what is the most effective way to capture that data. The PROMIS tool has been used often in the orthopedic space, developed by a few people in the population health science department at Duke, and we've dabbled in the QOR15 tool as well. very, very early, and we are highly interested in the data that Monty just shared with us in terms of its ultimate impact and utilization. As you know, it's a mandate that we have to capture that, and so there's great motivation to do that in the States right now.
Angie, are you probably...
Well, this conversation is, I think, a great opportunity to also remind us that these are conversations that we need to engage our patients in early. We talk about quality of recovery scales, and having read that scale, I kind of wonder if that fits all patients. You know, I think if our patients up front knew that they were going to be asked if they thought their life would be better afterwards, and there were tools and things they knew they could do to improve their post-operative experience. You know, we've talked a lot at this meeting about preoperative physical exercise, improving physical function, improving sleep. But there was even sort of a prehabilitation to minimize post-operative cognitive dysfunction discussion on using meditation strategies. I think anything that we can do in addition to medication to optimize the patient, engage the patients early in that process, then we can then say, well, we're going to ask you, were you effective in improving your own care afterwards? And I think that's when those quality of recovery scales should potentially even be brought to their attention before surgery so they know what they're going to see afterwards. But again, I wonder if that quality of recovery scale, we're asking the right questions for all the patients.
Well, and I think we're also very early in that curve. We're probably not capturing all the variables that we really want to capture. Pain is inadequately captured in many of the tools. They're obviously very scientifically vetted tools, but they're very nascent in their ability to capture some of those very important variables. I don't know that there's been a great tool designed for perioperative medicine as of yet.
Well, I think those are all great subjects. We could take a very deep dive in. We have a couple Slido questions, yes, that I think that we would be great for Angie. The first one here, what role does the general practitioner have in promoting smoking cessation in the pre-op? Is the preoperative clinic too late to get the ball rolling?
That's an excellent question. I think we rely heavily on our general practitioners to constantly remind our patients to stop smoking and provide resources for our patients. We work very hand in hand with our pre-op providers who are our general practitioners, our primary care providers who are not even within our system to engage them early. That's part of that perioperative medical team. We embrace our general practitioners, depend heavily upon them in terms of facilitating medical optimization because ultimately they're going to be caring for those patients after surgery. I think we as perioperative physicians have a window of time, 7, 10, 14 days, however long the length of stay is, in looking at postoperative care, and then within that 30 to 60-day window, the general practitioners are going to be responsible for those patients again. So I think we rely heavily on them for all of that.
Yeah. And one more question, because we're going to have to wrap things up, but it's kind of more of a yes or no, because again, we could really do a deep dive in this, but is perioperative medicine to be understood as a generic provider management system or a specific branch of practice?
Oh, fascinating question. So I think that gets into a more theoretical discussion of what perioperative medicine is. Yeah. I think it encompasses all specialties. It is truly multidisciplinary, and it requires a team-based approach.
Yay! That's great. Well, Angie, thank you so much for sitting down with us on TopMedTalk on the Smiths Medical booth in the Connection Center, booth 1519. I appreciate your insight and love having you with us to discuss all these great topics. Now, you were saying that there is a SPACI meeting that is coming up soon. When is that?
Yes, thank you for that. There is the Perioperative Medicine Summit 2019 is in Orlando, Florida, at the Waldorf Astoria, February 13th through the 19th. We will be there with a wide array of practitioners and experts in the field of perioperative medicine to discuss both not just risk assessment, but what we do with these findings when we can impact change and the timing of change and how we improve outcomes for our patients.
Well, wonderful. Well, thank you so much again. Be sure to listen to the live stream. We're going to be coming up shortly here with Stuart Grant to be talking a little bit more about pain management. I know we have some great questions on Slido that we're probably going to be addressing. Please be sure to subscribe, and you're entered to win. If you're here at the ASA and you subscribe during the weekend, you're entered to win our awesome Marshall amp, Bluetooth and wired speaker. It's great. I'm coveting it. I really want it for myself, but I guess we're going to have to give it away at some point. So be sure to subscribe, sign up for TopMedTalk, listen to the live stream, and please interact with us on Slido. You can ask any questions via the website SLIDO at TM and event code TMTASA18. So thanks. We look forward to more questions. Take the polls, and we'll catch you here shortly. Thanks so much.
TopMedTalk.